This is Dr. Pelle. He's the current resident on the spinal cord injury rehabilitation service. He's going to be talking today about fractures and spinal cord injury. Dr. Pelle, go ahead.
Yeah, hi everyone. My name is Dr. Andrew Pelle. I'm a second year here at University of Pennsylvania. And like Dr. Abramo said, we're going to talk about fractures and spinal cord injury. So here's an outline of the things we're going to talk about. Of course, we'll do my objectives, do an introduction, talk about the pathophysiology. We'll talk about the upper and lower extremity. We'll talk about measuring risk in these patients. We'll talk about the diagnostics and then ultimately treatment. So my primary objective is to summarize the pathophysiology, risk factors, diagnostics, and management of fractures in people with spinal cord injury. Introduction. So within the first 2 years after a spinal cord injury, you get this really rapid bone loss that mostly occurs in the load-bearing sites and ultimately can lead to fragility fractures. It's estimated that overall, all patients with spinal cord injury, the approximate risk of fracture is 2.2% per year. And this is actually a 23-fold increase in the femur fracture risk for, compared to uninjured controls. And then when you look at different timing, in the initial period, in the initial year, it's about 1% per year. And then after 20 years of having spinal cord injury, the risk is really, really high at 4.6%. So fragility fractures, what is that? So those are fractures that happen during low force impacts. And for spinal cord injured patients, this can happen in their normal activities of daily living. In this one study by this group, they found that 51% of the time they get fractures from falls from their wheelchair. 14% of the time it's during transfers, and 16% of the time it can be just with a collision from a door frame. You can even see fractures during range of motion exercises with some of these patients. So there's this one good study in the veteran population. In the VA hospital, they found that fractures are associated with a 7-fold increase in the length of stay compared to non-fracture-related hospitalizations. This is not during the initial injury where someone has their spinal cord injury. And then, as you would expect, the complications with this are pressure injuries, which are already high in this group, fracture non-union, DVTs, and then, of course, PEs would be increased risk as well, and then autonomic dysreflexia. Although the mortality risk is increased, it still is not statistically significant from the general population, the mortality, that is. So pathophysiology. So we'll talk about the pathophys a little bit. There's 2 defined phases, the acute phase and the chronic phase. Acute phase is defined as the first 2 years after an injury, and you get really fast bone loss that ultimately plateaus after about 2 years. And then in the chronic phase, it's just this ongoing bone loss that proceeds for decades. So a little more about the acute phase. So right after the injury, there's markers that indicate bone formation being suppressed. And at the same time, you're seeing increased bone resorption markers. And then by 2 years, 40% bone loss or bone mineral density loss in the lower extremities. It's really, really significant. During the chronic phase, this is about 2 to 3 years after an injury. It's not as well defined, but we can still talk about it. So one thing of note is that the mean time to the first fracture is 9 years after the injury. And the 50% of individuals with chronic SCI are osteoporotic based on hip studies or hip imaging. And then you can break that apart a little bit. For wheelchair users, 70% are osteoporotic, and then ambulatory patients, 15%. So those are really big numbers for wheelchair users and overall. I'm not going to get into all this crazy signaling, but I just want to talk about this sclerostin. So when you have mechanical unloading, you get elevated sclerostin, which leads to accelerated bone loss and inhibited bone formation. This has been seen in rodent and human studies, and there is a drug that is targets this molecule, this romosozumab. It's an anti-sclerostin antibody geared towards postmenopausal osteoporosis. Not great adverse events here: heart attacks, strokes, and death. So a little more about motor complete SCI. So you have really dramatic bone loss with these patients. Your bone is very richly innervated with sensory and sympathetic nerves. And when you lose this, you lose the osteoanabolic effects from these influences, from the sensory innervation influence. And this is thought to be a major contributing factor to the speed and the magnitude of bone loss. At the same time, you're getting a suppression of the anabolic factors, testosterone, growth hormone. There's other factors in the local bone environment, and even the atrophying muscle has paracrine influences on the bone. And then, as many of you know, when someone has an acute injury, we give them these really high doses of glucocorticoids. So you have a loss of anabolic factors, and then with glucocorticoids, you're even getting this huge catabolic factor at the same time. And then there's also local and systemic production of these cytokines that are catabolic or lead to catabolism. So let's talk about the lower extremity a little more. So the most common sites, the knee, ankle, and the hip in that order. When you look at the femur fracture, it's a 23-fold increase compared to able-bodied controls. And then when we look at just the lower leg overall, it's a five-fold increase in fracture. You can break apart different areas of the bone. The worst spot is the distal femur, and then comes the proximal tibia. So all right around that knee. A little bit of a broad range here. The bone loss in the proximal tibia is between 15 and 52% in chronic spinal cord injured patients. And at the distal femur, it's between 27 and 70%. There's the upper extremity. So as you would imagine, not as common. It is more common in tetraplegia, but in paraplegics, they actually, it's been seen that they have a greater bone density in the radial shaft. And as you can imagine, it's probably related to the increased mechanical load from going about your day using your arms the whole time. And if you fracture your radius, for these patients, it can be really devastating. It's going to severely interfere with their activities of daily living, their mobility, their job. So now we can talk about measuring risk in these patients. It's really tough to measure risk. So there's no established variable method, no threshold for SCI patients specifically. Most studies out there trying to measure risk, they use DEXA to measure bone mineral density. And it is overall the most popular way to measure bone mineral density in clinical practice. There's other ways to measure bone mineral density. Quantitative CT is really good, has a lot of advantages. You can actually partition the cortical and trabecular bone, assess the geometry. You can do these quantitative analysis on the bone, and overall there's less radiation, which is a plus. And then there's high resolution versions of this where you can even look at the microarchitecture of the trabecular bone. MRI is also popular. There's a lot of MRI machines out there. It's highly available. It is high resolution as well. DEXA is the most widely used, but you can get good data for clinical studies if you're using MRI or QCT. So let's talk about diagnostics. Not too much on this part. How do we diagnose osteoporosis in the general population? We look at T-scores. less than 2.5 for postmenopausal women and men over the age of 50, and then a Z-score of less than 2.0 for premenopausal and women and men under the age of 50. When it comes to the SCI population, it's the fracture risk prediction is not well defined here. So how would you treat your patient? So one of the first things you should do is look at the risk factors that they have. The major ones are having your spinal cord injury at less than the age of 16, female sex, the duration of spinal cord injury of 10 years or more, being motor complete, paraplegic, BMI less than 19, alcohol intake greater than 5 servings a day, tobacco use, prior fragility fracture, family history of fragility fracture. So what you should do as a doctor is you should talk to these people about the modifiable risk factors. And then there's also secondary causes of osteoporosis. You should try to screen them for thyroid dysfunction, vitamin D deficiency, and subsequent secondary hyperparathyroidism. Some drugs that we can use. Bisphosphonates are really popular in osteoporosis. When it comes to this, the population of spinal cord injured patients, it's not as well studied. So maybe this is good for people, the general population, but this is spinal cord injured patients. It's a unique type of osteoporosis. So there's some controversy about providing it. They still need more trials out there. And the side effects, you get oversuppression of the bone metabolism, esophageal irritation. You can get osteonecrosis of the jaw. And then if someone has vitamin D deficiency and you're giving them this, they can get osteomalacia, which can be painful. So, of course, monitor or check the vitamin D levels. Other treatments, not super great, not a lot of evidence on these, but there's denosumab. You also have teriparatide, pretty interesting electrical stim or functional electrical stim. You have a man here on the left where he's using functional electrical stim on a bike. This may stimulate some new bone formation and reduce bone loss. Still need more evidence with this. And then wheelchair use. So like we talked about earlier, half the time these people they're getting a fracture from falling out of their wheelchair or transferring, hitting their knee on their door frame. So you want to make sure your patient is using their wheelchair properly, safely, and that just going about that can be a really effective intervention. If they need a lighter or more maneuverable wheelchair, you can consider that. But of course, you have to make sure they have the skills to do this. So in an acute rehab setting, we're doing a lot of this. We're teaching them how to do transfers, teaching them how to use a wheelchair. So it can be, this is pretty relevant for us. And then just a little more about treatment. There's just, for actual fractures, once they happen, there's a wide variation in how to treat these. There's no real established guidelines on surgical versus conservative management. With non-surgical management, you get, what do you do? Immobilization, casts, braces, splints. This is the most common approach that people do. Surgical management, the bone's not quite as good. So if you put in an implant, there's a higher risk of failure due to poor bone quality, infection, and fracture non-union. And the non-union rates can be as high as 16%, which is really high. And the evidence for surgical fracture management is associated with lower complication rates in patients that are hospitalized for fractures. All right, and that's the end of my presentation. Thank you.
Great, thank you. I'm going to open up to the group. Any questions? All right, that sounds like you did a great job in kind of answering all the questions from the few participants we had this morning. So I have a couple questions. So if a therapist has a patient that comes to them with low bone mineral density or they've been a long time paraplegic, and let's say 20 years, and they haven't really walked. And they want to do some standing, they want to do some walking, they want to do some pretty aggressive therapy. What do you tell the therapist? What would your recommendations be as the clinician taking care of them?
Yeah, would this be someone that is motor complete or incomplete?
Yeah, they're complete.
Okay. You can try to do standing. There's not a lot of evidence that that's actually going to help with their bone density. I think it's probably fine to do, but from what I read, there's no evidence it's going to help them standing.
They're not interested in actually even doing it for bone density reasons. They just want to do it to kind of get mobile, do some new exercises they haven't done, and they're more concerned about the risk of fracture. Would you tell them that don't worry about it? Would you say get the
right
the DEXA, see where they're at, start treatment for it? What would you say to that?
So yeah, someone 20 years out, they probably have really, really brittle bones. I would probably recommend not to do it unless we have imaging of this person. We can kind of see what their hips look like and their knees. I would not recommend it.
Okay. And then what would your thought be in terms of somebody who is interested in like doing robotics or a walking program, both for health of the bones or just for doing it and kind of risk factor and what you do before getting them walking again?
Yeah. So the robotics, you would definitely want to get some imaging on them, see what their bones look like. That can help with the bone density, the robotics, although it is going to create an opportunity for fracture. So for a patient like that, I would want to make sure that their vitamin D is appropriate, their calcium intake is appropriate, and that they are not too osteoporotic.
And what would too osteoporotic be for you?
Yeah, I guess that's it's hard to say. There's no real hard guidelines in this situation from what I read.
Yeah, so I'll tell you what kind of my approach is. I generally allow patients to do these types of activities unless there's special consideration. They've had multiple fractures, knowing that there's a risk of fracture and having that conversation with the patient, because ultimately the only treatment for a lot of these issues is, or one of the potential treatments is not necessarily static walking, but, walking therapy, bracing, potentially robotics. And so you have to really weigh those things against each other and really explain that to the patient and allow the patient to kind of decide what their risk tolerance is, whether they want more studies, more imaging to get a better sense of that degree of risk.
Yeah. So yeah, exactly. It's pretty subjective with this. You have to take each patient and their unique situation into consideration.
Would you always just get a DEXA or would you get some of this other imaging?
I mean, depends what's available. DEXA is really, really available. So is MRI. I think the PQCT is probably the best. Yeah.
So what would you get for your patient, if a patient was on your service and wanted to know a little bit more about their bone health?
I'd probably get the QCT.
Oh, really? Okay. Great. Any other questions? Well, thank you. Looks like there might be one.
I was just going to say thank you, Dr. Pelle. That was good.
Yeah, so great job. This, as always, will be available on the website, on YouTube. So feel free to share with your friends, your family, cousins. This will be one in our our monthly series of resident in services on spinal cord injury topics. Again, thank you, Dr. Pelle, and have a good rest of your day and good weekend.
Thanks.